Good evening, everybody, and good afternoon or late good afternoon to our colleagues joining from various parts of the world. We warmly welcome you to another edition of the webinar series hosted jointly by the Sri Lanka Dental Association in an association with the Commonwealth Dental Association. Today we have with us a very eminent person all the way from UK to talk about how we are going to get around the problem of tooth wear in the general practice. Um, uh, Today we are going to have a webinar. Basically, the title will be Can tooth surface loss be effectively managed in the general practice? I am your moderator, Dr. Samarakon. On behalf of Sri Lanka Dental Association, I would like to welcome Dr. George Cherukara, who is a consultant in restorative dentistry of University of Aberdeen. And he is the Associate Director for the Clinical Sciences of the Institute of Dentistry in University of Aberdeen. So without taking any further time from Dr. George, I would like to welcome him and to invite him to do his presentation. Over to you, George.
Thank you very much, Dr. Samarakun. Thank you for this invitation, and thank you to the Sri Lankan Dental Association and the Commonwealth Dental Association for giving me this opportunity to share my thoughts with you all today. I would like to take this opportunity to thank a very, very dear and very important person in my professional life, and that is Professor D.Y.D. Samaravikrama. Professor Sam has been my PhD supervisor, my postgraduate trainer, and he has been all along my mentor and a guide to me ever since I met him in 1997 at Barts and London School of Medicine and Dentistry, also known as the Royal London Dental Institute. With that, I'd like to show you where I am, if I could manage to share the screen. So again, Dr. Samarakun, thank you for your invitation and for the introduction. And just for the international audience here, I thought I'll show where I am sitting presently. I'm in Scotland, and in Scotland, I am at Aberdeen. And Aberdeen has a Institute of Dentistry and a dental school, and that's our building. We are a very small school, one of the smallest in the UK and actually in Europe. We have an intake of 20 students every year, so it's a very nice, manageable cohort of students that we have, a very good working environment as well. With that, I thought it might be best to go to my subject matter of my presentation today, this webinar. My intention today is to suggest some tips and techniques for predictable and low-risk management of tooth surface loss, especially in a general practice setting. The durability and predictability is critical, and the ability to provide that care, especially during the current pandemic, COVID-19 pandemic, where we have restrictions regarding the use of aerosol generating procedures, which is one of the greatest risks for the transmission of the virus, the coronavirus, in clinical settings. So I'm going to suggest some techniques that might help us still to take care of our patients, particularly with relevance to this webinar, tooth surface loss. The plan is to talk to you about the different interventions that we could consider, both preventive and corrective interventions. And in these interventions, we have to use certain guides or steps we have to go through such as diagnostic wax-up. So I'll touch upon that. And the whole technique is based on the concept of dialing the occlusion, and we will try and bust some of the myths around the dial concept and the nervousness around using that technique. So as a dentist, I think we are not only dealing with the science and technology, but also more importantly, humanity. The culture, the socio-psycho cultural aspects of our patients is quite important. And in that respect, we need to consider what their expectations are. For example, the aesthetic expectations, where we play the role of an artist. And then we also have to consider the biomechanical principles that underlie or govern the various restorations or processes that we provide for our patients. So we play kind of an engineer's role in there as well. So while we are playing the role of a doctor, taking care of their ailment, oral and dental ailment, we have other roles to play as well. We need to keep that in our mind while we are going about managing our patients or helping our patients. With that said, the current mantra, as you all agree, is preservation of the existing or the remaining tooth structure while restoring form and function in a very predictable, stable, and in a maintainable manner. So we are looking at those procedures that would help us to do that in a very predictable manner. Again, time to thank Professor Samaravikrama for where I am in my career. Actually, I did this project with him as my supervisor during my PhD program. And I'd just like to play this video if I can. And here, oops, sorry, I clicked too soon there. No. I'll try that again one more time. My apologies. So you can see these two red spots here. That's where the pulp holes are on the tooth or very close to the pulp holes. And when we are preparing a tooth for a metal ceramic crown, you can see that the translucent area is the amount of tooth structure that was once there that we have now prepared. That, you all agree that we need to prepare about 1.2 to 1.5, depending upon what you believe and how you can provide that aesthetics with building up of a metal substructure and ceramic on top. You need the space for all of those materials. So we need to minimum have 1.2. Some textbooks or articles might suggest 1.5 millimeters. So that quite extensive reduction causes the amount of dentine, that is residual dentine, that is lying on top of the delicate pulp tissues. In this case, the red area suggests, and we measured it as 0.3 millimeters. So that is, very, very thin. It's almost a few paper thickness of dentin that's overlying the pulp tissue. So you can imagine the bruising, the damage we do cause the pulpal tissues and the biology cost of these invasive procedures, such as providing a full crown restoration on the tooth. And therefore, there is significant importance in doing conservative approach. And colleagues like Magne and others have suggested that building up teeth with composite resin can often restore the tooth's physical and mechanical properties, integrity of the tooth, and that we don't particularly want to provide or need to provide a crown to restore the form, structure, and integrity of the tooth. In fact, it is suggested that if we do, as we have shown here, we cause considerable biologic harm to the tooth. The biologic cost is too high. And then, of course, is the risk about the fracture of the tooth at the gingival levels. We have all come across cases where patients turn up to our clinics with tooth structure fractured at the gingival level because the tooth was restored with a full crown restoration. It's at this point, I think it's very relevant to look at what Professor Elderton way back in 1976 highlighted about a restorative cycle. That is a small class 1 or class 2 amalgam restoration. These days, it's more composite restorations, might progress to a more extensive restorations. And it's also been shown that every time we replace a restoration, that is, let's assume a class 2 amalgam restoration or a composite restoration, even worse, because the shade taking can be so good that we do not at some point know where the junction between the composite and the tooth is. And invariably, it's again suggested in the literature that about 40% of the 40% increase in volume of the cavity can result. That means every time we intervene, we are increasing the volume of tooth destruction. And therefore, the tooth eventually, for example, a cusp fracture, we restored it somehow, and then further fracture occurs because of this unsupported enamel probably here, which I probably didn't take care of it or plan in my planning. I didn't consider the biomechanical aspects of that, and therefore it breaks. And then I decide to put a crown on the tooth, and the crown has, again, if you look at the literature, says about 10 to 15 years of life. And if this patient first came to me as a 20, 21-year-old, in 20 years time or 30 years time, by the patient's about 50, when people say life just started, they're coming back to us with a situation where we may have to provide a post-core retained crown, which also has a certain life expectancy or shelf life, and which fails, and eventually we get a situation where the tooth probably fractures at the gingival level, and we call it an unrestorable situation. And at that point, we have to extract the tooth. So what our aim should be is to start in the restorative cycle to gain time, to delay the progression. So resorting to more conservative procedures that preserve the existing tooth tissue. That should be our primary goal at all times. Now to go to the next item on my webinar plan, we need to consider whether or when should we intervene, especially in tooth surface loss cases. And also to consider whether it is important to intervene in one way or the other. But before we go in detail about these interventions, let's have a brief discussion about some of the indices that we find in literature. We find several tooth wear indices, and I'll just mention two of them. One or both has its origins in one way or the other in the United Kingdom. One very popular, especially during my postgraduate years, was the one suggested by Smith and Knight called the tooth wear index, and many people are familiar with the index. But there's been some questions asked about the validity of this index in a general practice setup. And also it looks quite complex for me, for example, in my busy private or general practice setup, to use this on patients. And I believe strongly that these indices has a role in communication with our professionals. For example, when we are referring cases to our professional, we could use some of these, but on a day-to-day basis, I am not convinced about how useful these indices are. I do teach these indices to my students from a purely academic perspective, because I believe that they need to have an understanding of the availability or the options of using these indices. This is the other more recently developed one called the BV index, and a basic erosive wear examination index. Again, this particular one suggests that it might help the clinician or guide the clinician in the clinical management of the case. Again, quite a complex and it will take quite some time to get used to it in clinical practice. Moving on, let's look at a typical case that we might come across in our day-to-day clinical practice. The question I want to ask is, should we intervene in these kind of cases? And if we do, how do we intervene? I say this is a typical case because we're discussing tooth surface loss, and I can see there is some tooth surface loss. There is some alteration in the cervical enamel length or height of these teeth. Okay, the teeth are shortening. They are getting a bit wavy along the incisal edges. You can also see the cupping lesions appearing where the dentin is exposed. What happens with these cupping lesions, ladies and gentlemen, is that the surrounding enamel becomes unsupported. For enamel to stay, there should be dentin support. And when the cupping deepens, the increasingly unsupported enamel tends to chip off or break off. And that is why the length of the tooth starts to slowly shorten further and further. So to the question, should we intervene? Yes, definitely we should intervene. We should do something for these cases. But the question is, how do we intervene in these minimally involved tooth wear cases? The reason why I say we should intervene is because these are the cases that can progress to cause problems for the patients, consequences that can be quite challenging to the profession as well, the dentist, the clinician as well. You can see how this tooth is shortening because the unsupported enamel is chipping away gradually because nothing is being done about the ongoing tooth surface loss process that happens. I'm conscious that at the start of this webinar, I did not introduce the various etiologic factors that leads to tooth surface loss. I intentionally avoided that because I thought we are all aware of the various causes such as abrasion, attrition, erosion, and there may be, I might even generate some argument or debate or discussion if I use the term abfraction, because the profession is actively discussing the meaning of that word and the value of such biomechanical process that happens. But I won't go so much into it, but we will try to concentrate more on the clinical management of the cases after we look at some of the consequences of tooth surface loss. A significant consequence that, for example, Alex Milosevic, when he was at Liverpool, suggested is that with his group of patients, he suggested is that aesthetics was the most common complaint that his group of patients complained about or reported. About 60% of his patients reported appearance to be a major concern. And in addition to that, as the tooth surface loss progress, you can see increased loss of tooth to the extent they become completely unrestorable and potentially requires an overdenture or even extraction and replacement of these teeth. So that's one consequence. Some of the other consequences include gradual progression, as I mentioned, to the extent that there is not enough tooth structure to do much about it, especially if we are in the habit of resorting to indirect restorations. Indirect restorations, I mean crowns, for example, which requires further tooth preparations, and also the biomechanical principles surrounding it, such as retention and resistance forms, because we don't have enough tooth tissue to put a crown on top of it, even if we were to use the more modern luting techniques using bonding techniques. So in the bottom, you can see a patient that, one of my patients who was a 76-year-old lady, and yes, like Alex Milosevic's patients, and her concern was also appearance. So ladies and gentlemen, what I want to say is at this stage is that beauty and the need or the desire to look attractive is not just a concern of the youngsters, of the teens. And at that point, I might ask even a very relevant question: who for that matter is not young? Okay, we all, as I'm getting older, and I'm very reluctant to think that I'm getting older. I still feel young, and that's the case with most of us, I believe. So this desire for our patients to look attractive needs to be addressed, and that's where one of the interventions could help us. The other consequence, of course, is dentin sensitivity. And if we were to believe in the theory of hydrodynamic theory, we would know that the symptoms would depend upon the rapidity of the tooth surface loss, and also the balance between the reactionary and reparative dentin deposition versus the tooth surface loss that is happening. If that process, that is, the imbalance is in favor of the loss of tooth tissue compared to reparative techniques or defense mechanisms of our body, we will see what is happening here. We can see the pink of the pulp seeing through. So these are the teeth that are now at risk. In this particular case here, there is actually perforation into the pulp chamber over here. And you can see some of the discoloration that's due to the disintegration of the heme and the globin within the pulp. And in this kind of cases, it will end up as root canal treatments, and there is some possibly misguided belief that a root canal treated anterior teeth need to be restored with full crowns, but that's not the case. So that is another reason why I would suggest, what I'm going to suggest, the bonding techniques would be a way to manage this case. Nevertheless, this prospective audit from the Cardiff Dental School reported that the tooth process is rather slow, allowing the defense mechanisms to protect the pulp. And therefore, they even suggest that routine radiography is not indicated in tooth surface loss. But I would leave that decision to you, depending upon the severity of the tooth surface loss in your patients. You may or may not decide, make an informed decision about taking radiographs and treatment planning these cases. The other consequence, of course, is if, especially in a case like this, where there are extensively restored dentition, the tooth can wear away from the peripheral regions of the restorations, leaving sharp edges, leaving the restorations unsupported, and eventually dropping off or fracturing off, etc., requiring more extensive restoration of the tooth, involving at times quite radical procedures. And one of the most complex consequences, I believe, is especially in localized anterior tooth surface loss cases, is where there is considerable, like in this case, severe tooth surface loss localized to the anterior teeth, the incisors, and partly the canine incisal edges as well. But you can notice that the OVD, or the occlusal vertical dimension of this patient, is essentially maintained by the posterior dentition. So although teeth have worn away, there is no space available to place restoration. That is actually what confuses or perplexes us about how do we manage this case when there is no restoration. If I were to put some restoration here, obviously it will create a posterior open bite. So how do we go about it? Is that a concern? Is that a difficulty? Yes, it is a difficulty, but we can manage those cases. That's what we're going to look at in a minute. But before we look at it, I think I'll just mention that Alex Milosevic has published this article about signs and symptoms of tooth wear patients that appeared in their clinics and in the British Dental Journal in the year 2012. You can look up for further information there. So when I'm getting into the intervention, I want to emphasize on the prevention as the first step. And the first image that we saw of that minimal tooth wear case, I think what we should and how we should intervene is by instituting preventive measures rather than probably more active corrective measures. Prevention, and with prevention comes the need for educating the patient, particularly about the process of tooth surface loss and how their socio-cultural belief systems of or their lifestyle might be affecting the tooth surface loss, bringing it to their attention and making the appropriate behavioral changes. So that is more the medicine side of dentistry, I would say, having that chat and discussion with the patients. For example, talking them about their habits probably causing some of the wear. When I'm talking about education, it's not only the patients that we need to think about educating, but also the clinicians. And in this bottom picture here, you can see extensive, severely resolved bone dentition. And the reason why it is so bone in this area is because of the rough porcelain that was left on the palatal surface of these anterior crowns, which acted as essentially a sandpaper. And there is research that shows that unglazed porcelain has one of the greatest potential to cause harm or wear to the teeth when you compare other dental materials. So we need to be particularly careful. The importance there is to consider when you're providing a metal ceramic crown, should your occlusal surface or your palatal surface of your anterior teeth, should they be in ceramic or should they be in metal? I prefer my crowns to be in metal, occlusal or the biting surface to be in metal, because if I have an issue with occlusion, then I can manage those easily and polish them rather easily. That the metal can be much easily polished compared to the ceramic restoration. Polishing can be quite a task, and if you want to send them back to the lab for glazing it again, then it is an additional visit, and where the remuneration systems are different or such that there is a cost element, it may not be appreciated at that point. So there are some elements to consider there. And again, I briefly mentioned about etiology and the arguments about the appropriateness of the philosophy of abstraction, etc. We'll not get into a discussion on that, but the important thing is, again, to institute prevention at a very early stage, so these sort of lesions do not result. Very deep lesions, possibly where the pulp tissue can just be seen, or maybe it is sclerosed, you can see that there. Advising and educating the patients about the brushing habits, possibly on their dietary habits and other habits might be useful, and might even be a good idea to consider occlusal splints in patients who you diagnose to have bruxism as a problem, with deep antigonial notching or mesenteric hypertrophy, etc., can indicate to bruxism. Bruxism is a more complex issue, centrally mediated, of course, but from the history and examination, you might get an idea. And also looking at the type of wear, abrasive wear, which is wear faceting, flat planes, rather than cupping lesions appearing, might be indicative of bruxism. So in those cases, these sort of he-cured acrylic bite splints might be helpful, which needs to be, of course, carefully designed and carefully constructed. Again, another cause for tooth surface loss these days, especially, is erosion due to the diet's extrinsic acids. It could also be caused due to intrinsic acid, for example, in gastroesophageal reflux disease, or in eating disorder patients, bulimia, anorexia nervosa, etc. So in these patients, we need to be particularly careful about instituting the right educational support system for our patients. Consider having educational open days for um, patients who might be not just patients who suffer from eating disorders, but general patients, your general patient cohort, to expose them to the, the issue of these kind of psychological issues, and that might affect and lead to tooth surface loss. Then, of course, we all agree and know the importance of diet analysis and diet advice, and how this day and age lifestyles and aspirations lead to the consumption of quite harmful um, food and drink, quite harmful to the tooth, causing considerable wear of the teeth. And this is becoming an increasing problem, especially in children, with considerable prevalence of tooth surface loss in children, child population. While I'm talking about acidity of our food, we need to keep in our mind in passing that the importance of titratable acidity is of greater importance than the pH itself. So, for example, a comparable products, a comparable pH might have a drastically high result tooth wear effect on the tooth. So this Red Bull might be more harmful than Lucozade Sport, for example. So we need to have an understanding of that too. And I did mention briefly about the eating disorders and how we need to consider it is quite a complex situation or complex scenario, because there is considerable denial and shame associated with the admission about these habits, and patients might will be very reluctant to open up. So we may even have to look for physical signs such as Russell sign. So the Russell sign is if you look at the back of their fingers, particularly the index finger or some of the other fingers which they might use to induce vomiting. The introduction of these fingers into the mouth might cause friction or abrasion on the incisal edges and causing these scarring to happen in long-term cases. So seeing these kind of signs can give you an idea about the need to include multidisciplinary teams, clinical psychologists, for example, to help us. And we cannot turn a blind eye to them. We need to support these patients, which is important. And to summarize some of the prevention strategy, there's about 6 suggested by one of my contemporaries, which I'll show you in a minute, the paper itself. He suggests that 6 strategies include a strategy to reduce the frequency and severity of acid attack. And the second strategy he suggests is about enhancing the defense mechanisms. For example, the use of fluoride toothpaste or such. With fluoride toothpaste, I have certain concerns, which I'll come to in a minute. And the third is the enhancement of the recovery from an acid attack incident or episode, and substitution of diets with more tooth-friendly diet, food and drink. So we will have to do a diet analysis and diet advice, as I said, starting with the diet diary, of course, asking the patient to complete at least a 1 or 2 weekdays and also the weekend days. So if in case their diet varies between a week and weekends, you can capture that as well. Minimization of some of the mechanical factors, like, for example, toothbrushing immediately after an acid challenge. There's a habit for some to consume orange juice as part of your breakfast, and then before going out to work, probably brushing their teeth. And then if that is very close to that acid challenge that happens, the tooth surface loss risk is greater, of course. So reminding them of such risks would be critical. And then, of course, is the physical protection, the very simple process of applying some bonding agent on these teeth, or sufficiently thick composites would be useful, which is what we're going to discuss in more detail later. All of this, yes, before that, I mentioned about the concern I have about fluoride. My concern about fluoride is that what I am going to suggest is using a bonding technique to restore these moderate severe tooth wear cases. And if you are using bonding technique, the use of fluoride might, that generates fluorapatite, might get in the way of preparing the tooth substrate with etching. That is, the etch pattern that results may not be as conducive for the quality of the interface, the bonding interface, or the hybrid zone that we call as beneficial or as durable. So therefore, I tend to do GC tooth mousse, which increases the mineral concentrations around the tooth, but may not be as difficult to etch as fluorapatite might be. It's yet to be researched on. Of course, this is just anecdotal view that I'm presenting there, of course. This is Satinder's paper that I quoted from earlier, the 6 strategies that he's suggesting, a very good paper that you can read up in Dental Update, summarizing the whole process of prevention. So in preventive intervention, just to recap, we can look at the various things that we have to do. For example, a diet diary, we need to advise on the plaque control habits or the oral hygiene habits of the patient, and eating disorders, and looking out for signs of that, gastroesophageal reflux disease, and if there is eating disorders or gastroesophageal reflux, then we may have to consider referring these patients to our medical colleagues. And early recognition is important. Even the slightest change in the appearance of the shape or form or the morphology or even the texture of the tooth is enough for us to put preventive strategies in place and ensure monitoring is in place as well. So behavior modification is important as well. And I tell my students that behavior modification or oral hygiene instructions or plaque control instructions are not a one-time event, but that is an ongoing, every appointment. I stress my students to have a talk to them about their plaque control. Look at the amount of plaque in their mouth. Is it reducing? Is it maintained, or is it increasing? And then to introduce them to plaque control instructions at every visit, even if the patient is coming for a filling or a periodontal care or whatever it is. Every visit, look up the plaque control status. Talk to them about the diet. If you are worried about tooth surface loss, talk to them about the diet and the acid content in their diet. That was about corrective step, which is my next item in my plan. Often tooth surface loss, this is what I tend to do sometimes, look at a case and put my hand on my head and ask questions. How am I dealing with it? Why is this happening? And when is the best time to intervene, etc. All these questions. And these questions are pertinent as well. How, why, what, when, and where. We need to have answers to that questions to effectively and durably and in the long term, predictably manage our tooth surface wear cases. When we consider that, we have to look at evidence, of course, and this is a paper in the evidence-based dentistry journal that Dominic has, one of Professor Sands and my student at the London, that is Barton in London, where he comments that we don't have much of an evidence, and what we do these days is essentially based on low-level evidence from experts and observational studies. and personal clinical experiences, which is what I just some time ago said about fluoride and GZ moves, etc. My own personal experience in managing some of these cases. And we often consider patients' values and belief systems when we are making some of the treatment planning decisions. Of course, we have to consult with them, don't we? So that's how we make our decisions. So there is no sound or strong evidence base to support or help us. So 100% of the time, that I'm 0% sure of what I am going to do is not particularly far from the truth. There is an element of truth in that. That's why I chose to put that picture in there. And again, sometimes we get a bit confused about what we have to do unless we give it a bit of thought and plan the case appropriately. So in brief, the corrective intervention could involve immediate intervention, and that involves, protecting, if the patient's complaining of dentine sensitivity, for example, address those concerns. If there is an immediate aesthetic concerns, address that, providing some aesthetic relief for the patient, especially some of our patients are very, very concerned, and it affects them psychologically as well. And then, of course, to reestablish the form and function and the shape of the teeth in the long term is our aim. So in the immediate intervention, as I mentioned, our primary aim is to relieve the symptoms, identify some of the etiologic factors, protect or implement measures that will protect the teeth from further damage, and advice regarding protective agents. Maybe apply some seal and protect to manage the sensitivity, or other agents such as bonding agents to protect the, you're sort of trying to laminate the tooth surface with bonding agent to protect against the acid attack. You might consider occlusal guards. I have put that in that particular color because I just want to highlight that, especially in eating disorder patients or patients suffering from gastroesophageal reflux. It's been suggested that there is a risk acid might collect and get stored within this occlusal guard, soft bite raising appliances or mouth guards, and that might do more harm. So be careful where and to who you prescribe occlusal guards. It might be useful to apply a bit of GZ tooth mousse or such materials within the mouth guard before putting it onto the tooth, so the teeth can be protected and will have longer lasting effect of these materials on the tooth. So you need to consider carefully the effect of what we do for these patients. Although the immediate perception might be the occlusal guards might guard against the acids, but actually the acids might leak in and stay there and cause more harm. Oral hygiene and diet advice, of course, as I mentioned earlier, is pertinent, as well as frequent monitoring as appropriate. Now, in corrective intervention, especially during these times, COVID-19 pandemic, where we are concerned about aerosol generation, my technique is going to be, or my suggestion to you is going to be, to consider the use of an additive approach rather than a subtractive approach. A subtractive approach is like tooth preparation for putting a crown on, for example. Instead of that, an additive approach. So if that is the tooth structure that is lost, you want to build that up and by adding on to it rather than reducing any more of the tooth structure and causing much harm. For that, one of the first things you have to do is make some good quality maxillary and mandibular impressions which are articulated, and then diagnostic wax up done. And from that diagnostic wax up, a stent or a template can be constructed, which can be used to build up the tooth and restore the shape and form of the tooth, including the occlusion appropriately. So the starting point, of course, is articulating maxillary and mandibular study models using a facebow transfer so that it is related to the articulator just as the maxillary teeth are related to the condylar joints. And at least an average value articulator must be used. I'm not suggesting the use of more complex, more expensive tools such as semi-adjustable articulator, a DINA average value articulator that can receive a Facebook transfer record would be sufficient. I did mention about diagnostic VAXUP, so I thought it might be useful to look up diagnostic VAXUP. So if that's my toothware case, I would make some study models, articulate them, and then instruct the lab about doing an ideal VAXUP where the teeth would look very aesthetic and in its correct golden proportions. And it would also help with our treatment planning, patient education, and the checking the practicality of the treatment that we want to do, and whether we can get ideal aesthetics as well as even the occlusal principles, whether the occlusal principles can be satisfied or not. Or satisfying the occlusal principles is important. Otherwise, that is one of the reasons why often these kind of restorations fail. And in diagnostic VAXUP, I mentioned about the role of golden proportions. So you can mention to your technicians about that. And of course, the mutually protected occlusion and the principles surrounding that philosophy, that is protrusive guidance, canine guidance in bilateral excursions, stable, uniformly distributed ICP contacts, very, very basic occlusion principles, nothing complex about that there at all. When we are especially managing this type of cases that I'm going to show you, that is localized anterior tooth surface loss. To give you a little bit more about the golden proportions, just in case there was a need for that, I would always ask my technicians to give a central incisor a length of about 10 millimeters, cervicoincisal height to be about 10 millimeters, maybe 9 millimeters, depending upon the general facial appearance of the patient. But it's generally considered an average cervicoincisal height of a central incisor is about 10 millimeters, and the mesiodistal dimension or the width of a central incisor is about 8 millimeters. That is, yeah, it is right, 8 millimeters. That is a ratio of 1:0.8. Okay, so that is the ratio that you might want to consider. That gives an ideal appearance of your central incisor, which is the main tooth that we look at when a patient is smiling at you, when your friend is smiling at you, etc. It's the central incisor. So generally in the golden proportion, it is suggested we start with the central incisors. Once we address the central incisor, we can then easily go back and follow the gradations that the golden proportions suggest, that the width of an anterior tooth is 60% of the width of the adjacent anterior tooth. So that tooth is less in mesiodistal dimension than the tooth in front. So that gradation, if that ratio is followed, usually we get a pleasing smile, which is what this textbook, sorry, I'll go back to it, Galip Gurel's Science and Art of Porcelain Laminate Veneer is, I think, a one-stop shop kind of textbook where he nicely describes about golden proportion and the various factors or aspects that you have to consider in creating a smile. Again, once a diagnostic VAXUP is done, patient education is still significant, even when we are planning and executing our treatment. And for that, what I usually do is once the diagnostic VAXUP is ready, on one half of the mouth, I would use composite dressing on a stent and apply it roughly as a mock-up. I appreciate that this does not look as aesthetic or as finished, but this is just a mock-up that I did and show the patient what the tooth will look like once it's finished, once the treatment is provided, whether that is a sort of thing the patients would appreciate or not. And at this point, I'll draw your attention to the back or the posterior part of the mouth. You can see the dentition that was uniformly in occlusion before this was applied. You know, there is posterior open bite here. So because there was no space here, and now I've gone and applied some composite restoration, particularly on the palatal surfaces and the incisal edges, to give a better appearance. We are increasing the occlusal vertical dimension, leaving posterior open bite situation. So we will look more into that. And at this point, I just thought it might be a good idea before I carry on to play this. I'll be more careful about, I was trying to stop the video. I'm not sure how I will do that, but let me try again. No, sorry. Yeah, I'll go here and I'll play the video. What's happening here is there is two surface loss. This is a Fasaco jaw, plastic jaw. So on a diagnostic wax-up, let's assume this is the diagnostic wax-up, and I will take I make a template using a transparent material, silicone material. We use Memosil, a silicone impression material of adequate thickness so that it's not too flexible. It can be freehand made, or it can be loaded in a tray and put against the diagnostic wax-up tooth and done it. I cannot seem to go back. Oh yeah, I can actually. Let me just go back and show you there. So that is where I put the template in the mouth. This is a Fasaco jaw in a phantom head, of course. I'm just putting it there to show the gap between the worn dentition and the template, which is what we're going to, that space is what we're going to fill with the composite resin. Okay, and I am going to load the template with composite resin and put the template back against the tooth once the tooth has been etched adequately, primed and boned applied separately, because the gold standard to this day is still the 3-step bonding technique. That is etch, wash, then apply the primer, air thin it, and then separately apply the bonding agent, air thin it, and cure it. Okay, so that 3-step gold standard is what I do in my practice, where I get predictable and durable bond quality rather than the more quicker and shortcut single step or 2-step procedures. So here I'm showing the space and I let it play again. And then, oops, sorry about that. Let's see if I can drag it onto there. So that's where, this is where I am isolating the teeth independently, or individual teeth are isolated. Many times I use the PTFE tape that the works people use, the trades people use. In here I've used a plastic mylar strip and provided some wooden wedges, so there's good adaptation to the cervical area to avoid overhang. Okay, and you will see how I'm etching, I'm scrubbing the tooth as against how I would manage a freshly prepared dentin, like in a class 2 cavity or a class 1 cavity. Here I am scrubbing the enamel because of the sclerotic dentin, reparative or secondary dentin that's or tertiary dentin that's formed there. Then apply the composite within the template, put it against the tooth in the mouth, and then I start just carefully shaping it. That has to be carefully done. This is where I put on the role, play the role of an artist. And try to get the shape and the form as good as I can to the patient's satisfaction. It is cured, and here you can see BTFE tape used. These tapes are usually used by plumbing tradespeople. That will protect the flash adhering to adjacent tooth, and by taking this off, I can take it off very easily. You don't need to use a fast handpiece, aero to handpiece. That is not good during these times of pandemic. I use a slow speed handpiece with polishing discs, which are very helpful to take, well short of the 60,000 RPM that the Scottish Dental Effectiveness Program guidelines suggest, and easily done carefully. Actually, it has to be used at a particularly low speed. If you use high speed, um, you might take too much of the composite away. So very carefully, and you have different polishing combs, stones, and rubber to get the right. And then there you go. When once all of the teeth are done, you restore the appearance and the form and function of the tooth. You can check the occlusion and satisfy that the occlusion is okay as well. Of course, in these cases, what you will see is there will be posterior open bite, but we will talk about it in a minute. Okay, and I thought it is important, and if I'm advising my colleagues in primary care or general practice setup to use this, I thought it'll be useful to show what my students in the final years does, and that to show and prove that my students can do it very well. And therefore, it's quite reasonable for me to suggest the more experienced practitioners in practice can do it rather easily, I think, without much issue. So here what the student has done is made some maxillary and mandibular impressions, articulated them, made a diagnostic wax up, and in this case, for educating the patient, to show the patient, to get the informed consent of the patient. The student actually made a template on the diagnostic wax up, loaded it with some of the ProTemp or the composite resin temporary crown material into this template and inserted into the patient's mouth without etching or without prepping the tooth at all. And in this, while doing this, and I don't actually mind there being some moisture on the teeth, such as saliva, because I want to be able to flick off this rather easily. So in one piece, I insert it in, and once it's set, I take it out and I show this is what the tooth will look like. Of course, all of these flash will be removed before showing the patient. You can carefully remove it and give a general idea to the patient how it might look. Very important that the patient has a feel of how the bite will be, because I mentioned again earlier, the posterior occlusion would be off, that is open, and patients need to know what they're going to feel like. Otherwise, they will be not particularly happy if they come to know of it after all of the treatment is completed. They might be in for a shock. So again, my student put some rubber dam on for good isolation. As you would agree, for bonding technique, isolation is critical. Otherwise, the durability of that bond is suspect. And then finished off by building up the teeth and providing some partial dentures to increase the occlusal surface area available for the patient to work with. Of course, I'm sure everyone will notice that the composites could probably be improved. And that's what we do usually. One of us, the supervisors, will get involved at this stage and improve the appearance of the teeth before the patient is discharged. This photograph was taken soon after the build-ups were done to show what the student's work is before any support was given to the student to enhance the appearance of the restorations they carried out. So that was start, and that's the end. By doing this kind of build-ups, direct composite build-ups, an additive technique, you increase the vertical dimension, creating the restorative space at the back, creating more space for a denture and prosthetic teeth to be placed. In some ways, equating or equilibrizing or getting the occlusal plane in line as well, because you can see that over-erupted tooth there. The molar on either side are over-erupted, so that can to extent be managed. While talking about space in tooth wear, because of alveolar compensation, the space, the restorative space may be lost or not be there. In these cases, there is suggestion that there are different ways we can get space. It could be rather drastic or radical through crown lengthening procedures maybe, or taking a fast handpiece to the tooth to cut the tooth away to create the space, which is what we conventionally do if we were to crown a tooth, prepare the tooth, reduce the tooth to accommodate the restorative material there for the crown. And we could use orthodontic, we could seek the support of an orthodontist to put an orthodontic appliance and intrude or extrude the tooth, or we can arbitrarily increase the occlusal vertical dimension, like I showed in that student's case, just build up as required with direct composite resin, and provide the, or replace the appropriate shape and form of the tooth. Again, I thought I'll show you another case. In this case, it's interesting to see that this case came back from our primary care environment, and the patient's history suggested that resin composite restorations were placed on the palatal surface and the incisal surfaces to improve the appearance as well as to take care of the erosive lesions of the tooth. However, 2 weeks after the clinician placed the restorations came off, patient went back, and that was again replaced. And again, after 2 weeks, the restorations came back. So this is one of the most frequent questions that I'm asked when I suggest to practitioners about building up teeth, worn teeth, rather than putting crowns or onlays, etc., on teeth. They ask that it doesn't seem to stay on, and it tend to debone or chip away. And let's say what Maria had to say about that. So again, as a stepwise approach, step by step, she took some primary good quality maxillary and mandibular impressions. She, along with the tutor technicians that we have, diagnostically waxed up the anterior dentition on a DINAR average value articulator. And at that point, you can see that the posterior dentition is off. When I say off, there is open bite because of this buildup. And one of the questions again that my students as well as practitioners ask is, how do we decide how much to increase the bite by, and what this separation might be? How much can we increase it by? Is there a limit? And my answer usually is, there is no limit in some ways, because what you're looking at is giving a particular shape that is aesthetically appealing to the patient, following the golden proportion principles, and you're building up the tooth. So how much do you have to, how much dental materials do you have to apply? In this case, wax during the diagnostic setup or wax up stage. How much wax do you have to put on these teeth to make those teeth look decent enough to have a certain appeal or beauty to it? So that is how much you can raise the bite by. So in this case, although this may not be millimeter measurements, I usually call it units. It was a 2-unit increase in the OBD to provide adequate. If there was more extensive tooth surface loss, maybe we may have to increase it by 3 or 4 units. So it is guided by restorative need always. So once you have done the diagnostic waxum, Maria learned that she has to satisfy the occlusal principles, and therefore on the articulator, once the diagnostic waxum was done, she did check the bilateral excursion guidance and assured that they are more or less on the canines. And if the lateral incisors are built up, and that is when that composite that's built up later in clinic might chip off or break off. So she knows now that that needs to be avoided. There should be, canine guidance and the other teeth disoccluding. And in protrusive guidance, as many anterior teeth needs to be involved in that guidance, a shared guidance. So 1 or 2 teeth are not taking the brunt of it, and which might cause the composite to chip off. So she came up with a suggestion and called it toast. So she knows that the occlusion should be managed appropriately. Then the next thing that she's learned was that the incisal thickness, not only the incisal thickness, but also the palatal thickness, that if that's where you're putting the composite resin on, should be adequately thick. And usually we say roughly about 2 millimeter thickness would be nice. Okay, that give that composite resin the structural integrity, the mechanical ability to withstand the forces of occlusion, at least for the medium term. She also learned about the importance of the bonding interface and how that area should be dealt with, and how etching should be done, and that the etched surface should not be over dried, and that there should be some wetness or moisture there, so that the collagen that are exposed after the minerals have been etched are standing up like crop in a paddy field, for example, so that they don't fall down when you're blasting that air, in which case the primer and the bonding agent will not infiltrate that collagen network and provide a stable and durable and predictable bond interface, what we call the hybrid zone. So she learned about that. And she learned also that the starting point often, although she put it at the end, she knows that the starting point always is good quality primary impressions. Good quality primary impressions that do not have any air bubbles on the occlusal surfaces, incisal surfaces, etc. So she learned that. And that's what she shared with her peers in a group discussion. So that's the palatal surfaces, and that's the sort of, in this case, what she's showing is a putty being used to make a template. A disadvantages of using putty like this is that you cannot light cure it. So when you apply the composite and remove this putty without curing the composite may lift off the tooth and may cause problems for you. So it's usually useful to use a transparent material that you can cure through. So that's what the putty or the template will look like. And then you can apply composite on that tooth indentations and put it on top of the tooth. So that was the hair case. We'll start appearing like that, and finishing increased the occlusal vertical dimension, as you can see, just as you saw on the articulator. So what you see on the articulator is what you're transferring into the patient's mouth, because you have studied it, you have checked it, and you have satisfied the biomechanical aspects of what you're trying to do. So that's useful. And then the importance of oral plaque care is something that she eventually learned, because you can see one of the problems with these sort of direct composite buildups is if you're not careful, it can cause some marginal inflammation, as you can see here, because of some overhanging restorations that would probably we did not address, and those things have to be addressed as well. Again, management of space is nicely written up by now current colleague here, Richard Ibbetson, and his team in Dental Update. Again, as a good read. I'll direct you to that. And then I spoke about raising the post-occlusal vertical dimension, leaving posterior open bite, which is what Dahl concept is. And there's some mistrust about this concept. So I thought it might be useful to bust the myth behind it and clarify the safety of using this technique actually. So it was first advised by Dahl, who used actually a removable prosthesis to drive in over erupted teeth, to cause that axial movement of the teeth to create restorative space where teeth have over erupted and lost the restorative space, as in that picture there, the edentulous gap, there is not much of a space, and the occlusal plane would be rather strange. So they use this device to drive those teeth up into the maxillary alveolus to create improved space for a restoration. And that we now extensively use in the management of tooth-wear cases such as this. Another case of mine, this is an example where the sclerotic dentine, you can see, to get that durable bone, you need to scrub these dentin here a bit aggressively, because the sclerotic dentin is more mineralized than normal dentin is. So to create that edge pattern or the substrate that is conducive to durable bonding, slight scrubbing is a good idea. And then good isolation, and then you can build up the teeth. And you can see the teeth have been built up, and the occlusion has been raised on the posterior teeth. And the building up always depends upon how much. You may not always give a golden proportion smile to every patient of yours. It's patient dependent as well as to what they are looking for. In a global sense, I would say there is some mistrust, as I mentioned about it earlier. It's still considered a new technique, uncharted waters for some. And it's against the traditional taught principles of occlusion. You don't leave occlusion open like that. If you're providing a restoration, if you're providing an amalgam or a composite or a crown, you ensure that there are equal posterior and anterior occlusal stops. The so-called mutually protected occlusion, where the posterior teeth protect the anterior teeth and the anterior teeth protect the posterior teeth. Okay, so in intercuspal position, when people just bite together, the heavy bite is on the posterior teeth, very, very slight convex on the anterior teeth. But here, what we are doing, what I'm asking my students to do is put all the load on those composite resin buildups in the anterior teeth and leave the posterior dentition completely off contact. And that's against traditional principle, and that understandably caused considerable concern for some clinicians. But as you will see in a minute, that considerable research has shown that it is very safe to do so. And there might be a belief that putting a crown or indirect restorations makes more business sense, possibly. I could be wrong, rather than doing a composite build-up. Okay, because ultimately I am involved in the business of dentistry as well, because that's what lets me live my life. So does that or should that get in the way of our decision making? That's for each one of us to decide what is in the best interest of our patients. And I believe that is the fundamental and principal factor that we should keep in mind, the best interest of our patients. Having said about literature and research behind DAL, the Eastman Group has done considerable amount of work on it, and they have actually looked at over a period of 10 years to see what happens in these kind of cases that they have built with composite resins. And they say 94 to 100% of the times the objectives were achieved. What were the objectives? To protect the teeth, replace the form and function of the teeth, and also stability of the occlusion as well. They were achieved. Let's see how that was achieved. Because 40% of the time the intrusion happens. That is, if we are placing the entire occlusal loading on these built up anterior teeth, there is definitely some intrusion happening there. At the same time, the teeth that are not in contact start over erupting, or passive eruption, or extrude may be a more appropriate term. 60% of the time the extrusion happens, and all of these teeth that are apart will, within a period of 6 months or up to 1 or 2 years, will come back and establish contact. They identified that none of their patients had TMJ issues, and all it is the posterior contacts or the molar contacts that happens first, and all of the posterior teeth regained or re-established contacts progressively. And that is the time frame that I mentioned now. And they also noticed there was no pulpal consequences at all by overloading these anterior teeth. And the periodontal consequences was minimal and more like what I showed you in that last student's case, where there was some marginal gingivitis setting in, probably because of inadequate plaque removal or some overhanging bits of composite being left behind, but no periodontal disease. And for that matter, we know that occlusion does not play a big role in the progression of periodontal disease anyway. They also showed that there was no splaying of the teeth, because that's what one might wonder, if I am overloading those two teeth, do they start to splay up or separate? And that was not the cause. There was some mild discomfort during speech and chewing, and that was the case with my patients as well all of the time. They say that the initial couple of days they noticed, and our life is also such that, once we leave the surgery, the life takes over, and we tend to forget about how we chew, how we bite, etc. And many of my patients come back to say they can't remember how they felt it, because I usually call these patients back for a 3-month review or a 6-month review to say where the occlusion is now. And at that point, I can't remember. I think there was some discomfort couple of days, and then I can't remember. I never got in their way in their quality of life at all. And root resorption is another thing that many people think might be a big risk factor, but these 10-year studies have all shown that root resorption has not been identified as an issue at all. So it's very safe to do that. But I must say that this is a very dynamic process, so you cannot predetermine where the occlusal contacts might end up. So there is a little bit of maintenance involved, and you may have to adjust the occlusal interferences that might develop in time as the teeth extrude and come back into occlusion. So monitoring is important, and slight adjustments might be a good idea. Again, to just to conclude all of that discussion with a paper that I can suggest, the DAL concept, very prominent clinicians, all of them are very respected in the United Kingdom. Martin Kelleher, Peter Briggs are all very well-known postgraduate trainers in the UK. So a good paper to read, again, in the British Dental Journal. So this is a case that I would like to show that I managed many years ago while I was a trainee with Professor Sam. This was an anterior tooth surface low. You can see some minor posterior tooth surface lows as well, but main issue for this patient was appearance, and it was not his concern. He mentioned that it was his wife's concern that she doesn't particularly like the way his teeth looks. And one of the things that his practitioner did, these are two metal ceramic crowns on the upper right central and upper left, upper right lateral incisors. They show that, and they're short as well. What happened was they were of normal size like the rest of the teeth, but as the tooth wear progressed, the practitioner thought it might be a good idea to trim the metal ceramic crowns so they all looked alike. So that's what how the patient came to me. So I took off the metal ceramic crowns and made impressions, made a diagnostic wax up, and changed it to that. Okay, so all of these are direct composite buildups. These two are crowns, of course, because they had crowns. They had prepared the teeth prepared with finish lines. So what I did is I used indirect composite resin as the crown material here instead of ceramic, because the optic properties, I wanted the material's optic properties to match. So I used the indirect composite resin to match the optic properties of the direct composite resin, and I built up those teeth. And this was lab constructed, of course. This was made by myself chairside. So it shows that, yes, if you spend a little bit of time, you can create reasonably satisfactory looking teeth. This slide is just to show the importance of the incisal edge and the thickness of the material that you put on the palatal surfaces of the wound dentition. At least 2 millimeters of thickness is critical. If you do not do that, then all of these buildups will chip off or break off. This is the paper that I was mentioning about, led by Ken Hemmings, a 10-year study. This is a series of study. They looked at 3 years, 5 years, 7 years, and then 10-year study. And they say that, yes, there is some maintenance required, but management of especially anterior tooth surface loss by providing direct composite restoration by increasing the occlusal vertical dimension is a viable treatment option when they looked at over a 10-year period. So that is, again, further evidence to suggest that, yes, we can do it. We can do it rather reliably without much of an issue, actually. So just to say that tooth surface loss is multifactorial, but we need to be careful in our treatment planning. It's not about putting a load of composite restoration on these teeth. It is about doing some diagnostic wax up, checking the dynamic occlusion on an articulator. An average value articulator would suffice, in my experience, and then transferring that into the patient's mouth. But at the same time, addressing patient education, the prevention aspects as well, risk assessment, for example. So therefore, I think most of the cases are well within the remit of most dentists in primary care or in general practice setup, and can be easily managed. There are very few cases that may have to be referred to specialists, especially full mouth tooth surface loss cases where the occlusion has to be reorganized, where a semi-adjustable articulator may have to be used, where probably indirect restorations might come into play, where the management of occlusion might be quite a task or complex or carefully managed. Except for that cases, majority of the cases can be managed in primary care environment. And using this direct additive technique that you use chairside, you can restore the shape and function of the teeth without a biology cost, without doing more harm to the tooth, without having to reduce the already reduced dentition. The habits have caused much tooth surface loss, and you don't have put a burr onto the tooth now. And most of the finishing and polishing can also be done without much aerosol produced as well. And therefore, in the current pandemic, I think this technique is pertinent and is of a particular use and value. I just want to go back to this video that I played showing how much damage we can do when we put an aorta or a diamond burr on a tooth to cut a tooth to prepare a crown. Considerable damage, more damage than tooth wear can cause. So we need to keep that in mind and plan our cases appropriately. So that's the end of our webinar here today. And at this point, I would again give my heartfelt thanks to both the Sri Lankan Dental Association and the Commonwealth Dental Association. I guess that horn is appropriate warning that it's about time that I concluded this webinar. I would also give another big thank you to Professor Samaravikrama for being my tutor, my mentor, and my guide throughout, and ever since 1997, even to this day, and I'm eternally grateful for that. Thank you very much.
Thank you, George, for an excellent presentation. In fact, I think you covered most of the, not only the most viable points, and you went to the extent of doing some, or rather giving some information for our postgraduate students as well. Thank you so much for that. And we have a number of questions coming in from our chats. So may I forward it to you?
Yes, definitely. So should I stop sharing the screen or can I?
No, you can stay at that level. What I'll do is I'll ask the questions from you like this, and you can answer to the general public. All right?
That's fine. I thought I have to look up a chat or something. No, that's
no, that's fine. So the first question is, one participant has asked, how long should the occlusal splints be employed in parafunctional patients?
My experience is that is usually an ongoing. There is no a time frame for that, because as I mentioned, bruxism, parafunction, etc., can often be a centrally mediated problem, an issue, very difficult to diagnose often. And many a times, when I give my patients a Michigan splint, for example, it is with long-term use in mind. Mind you, there is also research to suggest that once you wear one of these splint, there is repositioning of the TM joints and also the occlusion in centric relation or retruded precentric relationship, etc., or retruded contact position, that when the patient discontinues wearing these splints, they might find increasing interferences and discomfort. At one point, one might want to be careful about adjusting those interferences. And again, you have to go back to the laboratory at that stage, articulated study cast, to check the effect that will happen on adjusting the occlusion. So my short answer is usually for parafunction, splints are more long-term rather than a short-term.
Okay, thank you. And the second question is, how frequently should we be applying bonding agents on the palatal erosive tooth wear to act as a physical barrier?
That is a good question, but because remember that if you're applying it as a preventive strategy, not as a corrective intervention for building up the palatal surfaces, just kind of, as I said, laminating the palatal surfaces, then what you need to remember is these bonding agents are easily worn off. The bonding agents do not contain any filler in it. So therefore they don't last for too long, maybe a month or less probably. So yes, you're right that these patients have to be monitored more frequently, and depending upon their behavioral change modifications that are happening, you may have to apply the bonding agent repeatedly. But the important thing is to consider not only just applying the physical barrier, but also bringing about that risk reduction by changing their behavioral characteristics, diet analysis and advice, and addressing why that tooth surface loss is happening, what are the risk factors involved, and eliminating that. The physical barrier is just one of the interventions, of course.
All right. And being on the same subject, another person has asked, is now when you brush the acid etchant on the surface of the sclerosed dentine, is it enough to overcome the resistance to etching? And she has also asked, I mean, is there a requirement to increase the etching time?
Uh, I would say yes to both. I'm sorry, I should have looked at before coming into the webinar. I've got to look up the paper that actually talks about how one should manage sclerotic dentine. It's a German paper published in the 80s. I forget the name. Never mind. What the team suggests is scrubbing with slightly increased time would be better than treating how we treat a freshly cut dentine surface, like for a cavity that we have prepared that just freshly cut, which we know needs to be delicately handled. But whereas the sclerotic dentine can be, like I showed in the video, maybe about 30 to 40 seconds of scrubbing might help. Depending upon the intensity of the sclerotic dentine, of course. Mind you, there are cases that might appear in our practices that might have ongoing tooth surface loss. So the dentine would appear like etched dentine, like with a matte finish. So you don't want to go and scrub those dentine. It is the dentine, that glassy appearance that you show. That couple of my slides are pictures that showed the pulp being covered by glassy looking material, very sclerotic material that you might want to apply a little bit of scrubbing action.
Okay, thank you for that. And there's another one. He has asked whether, I mean, this is regarding the some of the photos that you have shown regarding the buildup of anterior teeth, and he is asking what are the options for the posterior to establish the posterior contacts of those.
It depends. If we are just managing anterior tooth surface loss, I would not do anything to the posterior tooth at that point. And that is also the reason why I feel that this can be easily managed in general practice environment, because things get more complex if we have to place posterior restorations. That is where occlusal management becomes complex, and greater risk of getting things wrong, especially if we have to prepare teeth, etc. So here we are not doing anything to the posterior teeth. If there are some mild cusping, etc., cupping of the dentine, exposing the dentine, you can cover them off with some direct composite buildups, which I normally do. Otherwise, you're expecting these posterior teeth to extrude and regain contacts. And that's what all of the papers that I suggest, and that's my own personal experience in my clinical practice.
Okay, and going on to the same topic, like when you build up the anterior teeth, they have asked what is the increase of vertical dimension that maximally that you can go to.
Yes, that is a very relevant question, and that is also one of the most frequent questions, and the confusion that is amongst most of the students and clinicians, what is there a formula to decide how much we increase the bite by? That is where I showed you. You increase uh, to whatever you think is appropriate or is required. The usual term that is used is depends upon the restorative need. Okay, if I did say that, you need to have at least 2 millimeters of composite resin thickness for appropriate mechanical and physical properties and to resist wear and fracture, etc. Or is if that is the case, in moderate cases, that's all that you might require to increase. But if in a more moderate or in a severe case where there is considerable buildup of the lost tooth structure required, you might have to build up or increase the occlusal vertical dimension by about 5 or 6 millimeters. Now, if you read some of those papers, like the one that I suggested, written by my good colleague, Professor Ibbetson, he would say, and others, Shiliana Ilias, my contemporary, they suggest that occlusal vertical dimension can be increased considerably, even 7, 8, 9 millimeters can be increased, because the muscle fibers, the muscle spindles have great threshold. And in fact, especially if there is parafunction and bruxism, there is also suggestion that that increasing of the muscle spindle fibers actually helps with the habit, with reducing the muscular forces applied, and thereby helping with the occlusal loading or the abrasion or the tooth surface loss aspects. So there is multiple benefits in raising the occlusal vertical dimension. It helps to protect the teeth by guarding the muscles.
And I'm afraid questions are, pouring in. Would you mind if I forward two more questions to you?
For me, it is a Sunday, so I am here.
All right. Okay. Thank you. Another one just asked, what advice do you give to your patients after building up anterior teeth with composites about cautions, like eating and the time scales of when the posterior teeth are likely to come into contact?
Yes, there, depending upon the etiology that you identified, okay, if it is due to habits or other reasons and not erosion, usually I give my patients either a soft bite guard or a Michigan splint to protect the buildups that I did. And I would advise them to wear it in the long term as well. But if it is erosive cause, and I suspect either intrinsic or extrinsic, intrinsic could be because of gastroesophageal reflux, I would have referred the patient to the patient's general practitioner, medical practitioner, or a specialist gastroenterologist for its management. Or if it is a behavioral problem such as eating disorders, then I would have enlisted the support. We have clinical networks here, managed clinical networks. We see that is a team of professionals involved in the provision of care for patients. So we would manage like that. And I guess that answers the first part of that question.
Yeah, that's right.
The second part of the question was the time frame. And
Yeah.
that 10-year study and other studies have shown that it takes about, uh, it can take majority of the cases up to 6 months, but very rarely 10 to 12, 12 to 24 months. In my experience, what I have noticed is within 6 months, patients have forgotten me as well because everything is back to normal. And in my experience, all of these years that I've been managing according to this technique, there was only one patient that ever came back to me upset and asked me to take away the composite resin buildups. And her concern was that she didn't like the way she was biting and she didn't tolerate it. that is a multitude of patients, just one patient. But then that is also a patient probably I should have spent a little bit more time talking to. I probably might have been a bit rushed in executing the treatment because there were some flags raised about the patient's ability to cope with what I was trying to do.
Okay. And another question is it advisable to use injection molding technique of composites using clear silicon indexes to build up anterior teeth?
There are various techniques available. The one that I showed is only one of them. Injection molding that is creating a whole, I don't know how you propose to do that, but it's about injecting into the template, fine. Or some people, what they do is they make a full template and like a mouth guard, and they just insert into the mouth with composite in every tooth and insert in. I don't like that technique because what I find is I find that they all get connected together as a one piece across, and I find it quite a task to separate them and then provide, make teeth individual, separate. It's quite a task, and you don't want to leave teeth connected together with build-up. That would be bad. That would be very bad for me, in my opinion.
Yeah.
And I'm sure Professor Sam would agree with me with that.
Yeah.
Very true, George. Thank you very much for that excellent presentation. Yes, if you would do that method, and it's very, very difficult to make sure that the interdental contacts are maintained. They all get fused,
Yes.
and cleaning becomes a major problem, as we have found out, haven't we, George?
Yes, that is
Yes.
true. I tend to try and avoid that.
That's right.
I'd like to forward the last final question. Given the role MMPs play in bond stability, do you routinely apply MMP inhibitors prior to dentin bonding?
Ooh, that
And
is
there any sorry, yeah, go on.
no. Complete the question.
And is there any evidence that these inhibitors work actually?
The answer to all of that is no. MMPs have a significant, because one might wonder, where does the MMPs come from? These cytokines come from the dentinal tubules, and it's been suggested that the MMPs can inhibit the polymerization of the resin composites. But I think at my level, at the current time, doesn't seem to be affecting my bone durability, and I'm not overly, I think it's more an academic aspect as well. It's quite like there was at one point a suggestion that the use of composites and bonding resins can cause hormonal issues, particularly focusing towards males, patients, etc. I don't see my male patients having a problem with the number of composite, the truckloads of composites that I use on those patients to build up these the bone dentition. So I think maybe I might regret in years to come for saying this, but at this point in time, the MMPs might be playing very subclinical or very low influence on bone quality as such. And there has not been any suggestion amongst, in my environment, my colleagues, about the use of MMP inhibitors before applying composite resin. I think it's more an academic. I do not know what Professor Sam would want to comment on that.
Thank you,
Yeah,
George. It is more important to control moisture
Yes.
during bonding than anything else. That's the one that decreases bond strength. Our inability to control moisture during the process and following the protocol very, very carefully. not to take shortcuts. And also George mentioned quite rightly, the gold standard still is the 3-step bonding procedure.
Yeah.
Yes, and that's one of my research interests that I'm getting into is about how we manage that substrate. When we say about moisture control, do we overdo it? Do we dry the dentin to the effect that all the collagen fibers are falling down and there is no way for the primer and the bone to infiltrate below that? You know, it just beds off the surface. So you want that to stay up like that, all the collagen. They don't want it to lie down so that
Absolutely right.
the hybrid zone can be created, bacteria.
Okay. Thank you so much, George, for taking time off from your busy schedule. I know you are a very busy clinician and as well as an academic as well. And to spending time with us, giving us very valuable insight. And I would like to thank Professor Sam specifically for arranging this lecture, liaising with Dr. George and introducing me to him, and coming up with very innovative ideas. And I would like to thank the Commonwealth Dental Association as well for collaborating with Sri Lanka Dental Association to give the maximum to our clinicians from all over the world. And thank you so much for everybody who have joined in. I hope that you had a wonderful time, especially regarding this continuous education that we are striving to provide during this difficult time. And like what George rightfully mentioned, from the last slide, it is very much applicable to use these techniques in this difficult time, and we must employ this time as useful as much as possible to everybody in this sort of way. So thank you very much for everybody, or rather thank you very much on behalf of the Sri Lanka Dental Association for participating. And I like to mention the fact that our next lecture will be in 2 weeks' time on a Friday night at 8 p.m. India Standard Time. The lecturer will be Dr. Sonali Ranatunga, a consultant in restorative dentistry as well. So she'll be talking about the coronal restoration after the endodontically treated tooth. And I hope everybody will be joining for that lecture as well. Thank you very much and good night.
Thank you. Good night.
Thank you. Thank you, everyone.
Thank you, George. Thank you.
Thank you, Prof.
Thank you very much.